Okay, there we go. Okay, so we're gonna start talking about diabetes mellitus. It's a very long chapter, so I'm gonna cut it in maybe three, four videos. That way it doesn't become tedious for you. So before we start talking about diabetes and the medications used for diabetes, we need to talk about first insulin. We need to understand what is normal for the body, and then from there we'll start seeing the variations and how can those variations can form a disease. So the first thing is regarding insulin is made by the beta cells in the pancreas, and the function of insulin is to lower glucose levels in the blood. Very important they understand that that's the overall effect of insulin, to lower glucose levels in the blood. And the way it does it is by stimulating the cells in the body and make those cells open a door for glucose to go in. So every time we have a meal, uh, it's broken down into different portions, carbs, amino acids, fats, and then that gets absorbed into the body. And the carbs, sugars, they need to get into the blood cells. I mean the tissue cells. So they're floating around, moving around the body, on the bloodstream, and insulin is released from the pancreas, and insulin goes to all those cells in our body and helps open that door for glucose to go into the cells. So when we do a lab test, a blood work on that patient, after the effects of insulin, then glucose levels are gonna be normal or low. So having that as a background on how insulin works, now we need to talk. Now we can talk about the different types of diabetes. So we're gonna start with type 1 diabetes. Diabetes is an autoimmune disease. Basically, type 1 diabetes is diagnosed commonly in kids and adolescents, rarely in adults. The background that we have with this group of patients is that they had uh, a viral infection, a previous viral infection, a cold, a flu, a viral diarrhea, something like that. But it has to be viral. And then for some reason, the immune system, uh, a few weeks later or a few months later, they start attacking the beta cells in the pancreas. So without beta cells, the pancreas cannot make more insulin. So this patient now has no insulin. So every time that they eat something, there's no release of insulin, so those glucose stays in the blood, but the cells they need their energy. So what happens next? So the glucose levels they don't go in, they're not going into the cells, so the body has to rely on other sources of energy, since cannot use the carbs, the sugars in the bloodstream. So the next option for the body is to um, start destroying proteins. And the biggest tissue that has proteins is muscle. So now the body is eating the muscle in order to obtain that sugar, that carb needed for energy and continue functioning properly. Unfortunately, this is not something that works very well. And now the body has to jump to the next tissue to obtain those carbs, those sugars, and unfortunately, this tissue is very hard to break down, and that's the adipose tissue, the fats. Because it's very hard to break down, that's the reason it's not the first option for the body to break it down right away. That's why fat is very difficult to eliminate. It's the last tissue that is broken down. The problem that we have with fat tissue is the waste. When you're breaking down fats or adipose tissue, because it's fat soluble, it's able to provide the basic energy that the cells require to continue working. But unfortunately, in this breakdown, we have waste products, and those are called ketones. And just like any waste product in the body, ketones are acids. Like lactic acid, uric acid. Every time you hear acid in a component inside our body, most probably it's going to be a waste product. The exception will be gastric acid. Other than that, all the other acids are waste products and they have to be eliminated properly. Unfortunately, because ketones are fat soluble, they don't get eliminated through urine that easily. So this acid accumulates in their body and starts to break down the other tissues because of the acid properties that it has, especially the nervous system. So type 1 diabetes is again, like I told you, is an autoimmune disease where the patient makes no insulin. Obviously, the treatment is going to be provide insulin. Now, the other type of diabetes that we have is type 2 diabetes. And this one is more common on adults. Type 2 is the most common diabetes diagnosed, at least in this part of the world. 90 to 95% of the patients diagnosed will be a type 2. It's very commonly on adults until maybe one decade ago, or maybe two if we push it, where we have seen now kids, 7, 9-year-old kids with type 2 diabetes. And so what is the concern here? What is the problem? Is the lifestyle of the patient where they don't move too much and the intake of carbs is very high. It's a couch potato. So what happens, because the constant intake of carbs, there's a constant release of insulin throughout the day and maybe throughout the night. And then eventually the cells, they stop responding to insulin. An example for you to understand this, is a teenager. It's going on a date, and they grab the cologne, the perfume, and they put it on, and they start doing other stuff, and they're like, oh, I don't smell it anymore. The perfume is gone, the cologne is gone, so I'm gonna use more, and they put more. And then when they step out of the room, the whole house, everyone there, siblings, parents, like, hey, what the hell? You put the whole bottle on you. You have too much cologne. You have too much perfume. And the teenager would be, well, I don't sense it. So this overexposure of a stimulant, in this case, the perfume, make the receptors in the nose like, okay, that's it. We're not going to react to it anymore. It's there. That's it. Nothing much to do. And this is the same effect that happens with insulin. That constant release of insulin, eventually the cells of the body, they start responding to it. They're not sensitized. They resist it. They don't want to. So that's what we call insulin resistance. So the cells now, they don't respond to insulin, and the glucose cannot get into the cells. And now we have hyperglycemia. Now, like I was telling you, type 2 is a lifestyle mainly that produces this disease, where type 1 is autoimmune consequence. The other type of diabetes that we have is gestational diabetes, where the patient is pregnant, and during the pregnancy they get hyperglycemia. Now, for this, time frames are very important to understand. To properly diagnose gestational diabetes, usually the patient has to be pregnant a few weeks in, 15 weeks, 20 weeks into the pregnancy, and then start having the hyperglycemia. If for some reason the patient on the first visit to the OBGYN, I don't know, 4 or 6 weeks of pregnancy, and they're already having hyperglycemia, then that's not gestational diabetes. It can be a type 1, type 2. We need to do a better triage and see what really is going on. So gestational diabetes is diagnosed throughout the pregnancy, usually on the 15th week or 20th week. That's when we see it. And usually once the baby is delivered, the diabetes goes away, it disappears. If this doesn't happen and we do a follow-up on the patient 3 months later, 6 months later, and she has hyperglycemia, then the diagnosis of gestational diabetes it was wrong, and she has another type of diabetes. Or again, we have to double check type 1, type 2, or probably type 2. And it's known that 20% of the moms that went with a gestational diabetes eventually they'll have type 2 diabetes. So it's very important to do the follow-ups. So what happens in gestational diabetes? How they start making a hyperglycemia, high glucose high levels of glucose. So what happens here? The placenta is always gonna work in favor of the baby, kind of protect it, kind of help it develop and all that. And one of the things that the placenta does is to increase levels of cortisol, another hormone of the body that, as a function, is to increase glucose, and that glucose goes into the baby, and now the baby has enough glucose to feed the cells and those cells to multiply and make new tissue. The thing is, sometimes this cortisol can elevate glucose levels to an amount that the insulin from the mom is not enough to control it, and now we have hyperglycemia. Usually, the babies from this type of moms, they're above average regarding weight and size, and then once they're delivered, they go into a hypoglycemic state right away. So we need to check glucose levels and try to provide glucose and bring it down from the hyperglycemia until the baby is able to control its own glucose levels. So those are the three main diabetes: type 1, type 2, gestational. If you read other authors, they're going to say juvenile, they're going to say insulin dependent, non-insulin dependent, and they have a lot of definitions, but that has brought a lot of confusion when we are trying to diagnose a patient. That nowadays the new authors, they're saying, what, it's just type 1 when they don't make insulin, type 2 when there's a resistance to the actions of insulin, and gestational diabetes. Now, like I was telling you, regarding gestational diabetes, it's only during the pregnancy. Once the baby is delivered, the diabetes is gone, so we don't see a lot of consequences long-term of diabetes. Regarding the general population, a lot of diabetic patients, they don't know what is diabetes. You ask them, hey, you're diabetic since 5 years ago. What do you know about it? And they're going to tell you, well, I know that I'm sweet. I'm a very sweet person, and that's it. The doctor is jealous, and he doesn't want me to eat candies, chocolates. So with that type of knowledge, it's very hard for them to understand the disease, and from there, help themselves control it. So they need to understand that their type of diabetes and how it came from. So let me share a little bit the PowerPoint so we can see the long-term effects of diabetes. So just please be patient with me. Okay, here you go. Okay, so this is chapter 57. Okay. So complications of diabetes, long-term, it says here, macrovascular damage, heart disease, hypertension, stroke, hyperglycemia, altered lipid metabolism. Doesn't tell you much. So same thing, if you don't understand this, it's going to be very hard for you to explain things to the patient. So let's go very basic regarding diabetes. Independently of the type of diabetes, 1, 2, try to see it like this. If you have a glass of water and you start putting tablespoons of sugar, 1, 2, 3, 10, 15, 20, 50, the the quality of the water is going to be changing. It's going to become more thick. It's going to become honey. So try to see it like that's in the blood, same thing. We're going to have a physical change in the blood, where the more glucose we have, the thicker the blood becomes. So that means that the heart has to use more force to push the blood throughout the body. And that's how they get a heart disease. They start getting a heart failure that starts to grow because as a muscle has to grow in order to push that blood that is more heavy. Unfortunately, the heart is the only muscle that the bigger it gets, the weaker it gets. The hypertension and the stroke, those are consequences of the heart trying to push that blood that is heavy throughout the body. So it's gonna use more force of contraction that is gonna elevate the blood pressure, and on the capillaries, especially the capillaries from the brain, they're gonna rupture, and that's what we call stroke. Obviously hyperglycemia, and we'll see other changes that happens in the blood. Not right now, we'll see in the next slide. But now lipids. There's a change in the metabolism of lipids. So what happened? And we're going to emphasize here type 2 diabetes. Like I was telling you, the only function of insulin is to push glucose inside the cells. That's it. No other function, very straightforward. Every time insulin is released, glucose goes into the cells. And I mentioned type 2, there's a constant intake of carbs. So that means that the cell is going to have way too much sugar now inside. Too much that it's not going to use it. It's not going to use it all. So what happens when you don't use something? You put it in the storage. The first storage for glucose that's not being used is glycogen. And it goes on the liver. And every time we are fasting, a normal patient, every time they're fasting and there's no breakfast or no calorie intake, that glycogen is broken and now we have glucose. But in this case, again, insulin is putting sugar, too much sugar inside the cells, that the cells, okay, let's put it in storage, and glycogen is the storage form of glucose. Unfortunately, that storage form is not that big. So now the body has to look for another way to store all the sugar, and that's the adipose tissue. So all that extra glucose that wasn't converted into glycogen now is converted into fat cells, and now it's called adipose tissue or fat tissue. And that's the outer lipid metabolism. Okay, now let's talk about the microvascular damage. And this here, retinopathy. It's very common for diabetic patients, especially type 2, for them to go blind. So let me explain this a little bit more in detail. Glucose in the blood doesn't stay as glucose. The body loves to change everything. The body's a big laboratory, and glucose is changed into an alcohol. It doesn't stay as glucose in the bloodstream. It goes into an alcohol. And now it's going all over the body. And alcohol irritates nerves. So just a common example, if you have a cut and you pour alcohol over that cut, it's going to stink. Why? Because alcohol is irritating your pain receptors in that area that are exposed now. And depending on the nerve, that's what is going to happen. So, and right here, retinopathy, the patient goes blind because the retina is an extension of a nerve, just the ophthalmic nerve. And that alcohol is going to irritate the ophthalmic nerve to the point of destruction, and that's how the patient goes blind. Also here, sensory and motor neuropathy is known for them to lose sensation of their extremities, and it's the same thing. We have all this glucose turned into alcohol going all over the body, and it starts to irritate those cells. At the beginning, patient's gonna tell you, I feel numbness, I feel like ants underneath my skin on my fingertips or on my toes. Then it's gonna move to pain. You know, I have pain and I don't know how to control it. I take Tylenol, it doesn't work. And then after that, you're gonna do a follow-up. Hey, how's your pain? Oh, it's gone. Oh, good for you. No, now I don't feel nothing. I have no sensation because the nerve died. And that's where the amputation comes from. It's an infection. So in that type 2 diabetes, or that is not controlled, and that sensory nerve dies, if they get a cut under lower extremities, they're not going to sense it. They're not going to know what's going on. So if they don't know what's going on, obviously they're not going to take care of it. So it's very common for diabetic patients to have those cuts not sense them, and now they have an infection. And they don't sense the infection until, you know, smells, or, you know, now they found pus on their socks, on their shoes. And by the time they realize, oh shoot, I have an infection, you know, that unfortunately the infection now is too deep and the infection comes in. Regarding gastroparesis, means the stomach stops moving. And same thing, it's a nerve problem. The nerves innervating the stomach, they stop working, so the stomach starts responding to the process of digestion. This is a patient that's gonna eat and it's not gonna digest. And erectile dysfunction, try to see it again, because the quality of the blood is different, and the lack of nerves. So those are the complications that we see on the long run on those diabetic patients. Okay, so we're gonna finish this presentation right now. Keep it short, the videos, and I'll see you on the next one.